Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It's a great honor for me to be here in Aspetar Hospital. We will talk today mainly about trauma, dental trauma, dentoalveolar trauma, and dental implant. For me, it was at the beginning a little bit difficult how to communicate between the two subjects, but it's very easy. Dental trauma, it has the consequence by 30% of the cases, especially by severe cases, that we lose the tooth. Losing the tooth, that means we need to have a tooth substitute and dental implant, one of the best. First, how we would, our lecture will be about management of sport and acute dental trauma with dental implants. This is our team in Al Ahli Hospital. We're 13 dentists covering the whole spectrum of dentistry. I have no any potential or conflict of interest relation to this presentation, and will not be discussing any off-label or unapproved use of drugs or products in this presentation. Learning objectives for today, it will be to summarize the management of all classifications of sport and acute dental trauma as a summary, and after that we will demonstrate the best timing of doing dental implant post-tooth removal due to acute or sport dental trauma. At the last, we will make some discuss about the necessity of hard and soft tissue management by doing dental implant in aesthetic zone. This is where I lived in Damascus. This is my university. In Bremen, I did my specialty for oral surgery, and in Münster, my master degree for implantology. We have to choose our patients, we have to choose our cases, we have to choose also our place of work. This is very important for us to start doing any management for any patients, and of course, there's a lot of advices by this problem. The consent form, please, in this country, start with it always before doing any procedure. Sometimes by trauma, we have to deal directly with the patient because it's an emergency and not by the consent form, but please don't forget it. By management of sport and acute dental trauma, we have the best reference for this area, which is IADT, which is the International Association of Dental Traumatology. This association, they have the last revision for SORI is 2012, but it's still until today is very actual. We have this poster. Please, if you can tell everyone to have it in his work of place, in his school even, it will give some idea about how to manage the primary management of the fracture of the tooth or avulsion of the tooth or luxation or something like this. At the end, the specialist as a dentist or surgeon must be the one who make the treatment at the end. I will try not to go in detail by this classification of the dental trauma, because it is a very huge subject. We start by infraction. Infraction is a small fracture, and then we go to the animal fracture, and after that we see that we have the fracture with dentine exposure, and then we have the fracture with bulb exposure. We know all how to manage this small trauma because this is only a dental, and we manage it always with covering the dentine or the small area of dentine exposure with calcium hydroxide and doing a filling. For luxation and subluxation and intrusion and these cases, we have to do relocation for the tooth in the right position, and after that fixation with splinting the tooth. And you can see by this all how we manage it and the follow-up, how we will do that, and the details are for you maybe familiar to know about it. and you do it every day or every time you see the patients with luxation and like this is just to know how we classified the traumatology or the dental trauma. We come after that to fracture of the roots. The fracture of the root, it has also different stages of fracture. It could be on the upper part of the root, with the apical part of the root, or the middle part of the root. Every one of them with how to manage it and to deal with it. Thank you. For this case, for example, you see how it's a multiple fracture of the root. We have no root canal treatment for this tooth, by fixation only, and the fixation it was for 4 weeks. Sometimes we need by fracture of the root more than 4 weeks to make splinting for the tooth, and then after that the vitality is come back again, and there is no need after follow-up 5 years. For this case, recall there's no endodontics treatment was necessary, and we can see the some classification on the root apex. Avulsion, this is what we call one of the major problems which leads to tooth loosening. Avulsion, it's almost more than 40% of the cases will lead at the end by repositioning the tooth in its place and fixation of the tooth with splinting to have root resorption, internal or external root resorption. It will lead sometimes for infection. These problems, infection or root resorption, it leads for tooth extraction at the end. When we remove the tooth, we have to have a substitute, which is dental implant. Here we can see that the avulsion, it depends on time. If you have the right time to replace the tooth in the, to refix the tooth in its place, then you will have less complications. In this study, it was about 90 minutes. Most of the studies, they said also 60 minutes. This is the maximum time. If you keep the tooth, if the tooth dehydrated and replace it in the socket, then you will have more than 50 to 80% of the cases that you will have no good results or root resorption, and that means you have to extract the tooth, because by root resorption it happens always some infection and or some loosening of the tooth will be loose, then we have to lose the tooth and remove it. Splinting time is very important. By this slide you can see what's the splinting time for subluxation, 2 weeks, or extrusive luxation is 2 weeks, avulsion 2 weeks. The most of them 2 weeks. Only the intrusion, it needs 4 weeks, and the root fracture, as I told you, needs about 4 weeks. Alveolar fracture also, if by tooth luxation, it happens also that we have the alveolar fracture, it will be 4 weeks, and the root fracture also 4 months. Yeah, if it is in the cervical third, it needs 4 months. That means very high fracture line. By this slide, we can see also how we make the follow-up procedure. It is very important by tooth trauma to make follow-up. Even if there is no problem, nowadays, by the day of the treatment, you can have a problem by after a week, or by 2 weeks, or by 1 month, and sometimes the follow-up, it will be somehow 5 years. You need to follow up the tooth and see if there's any time to be interfere with root canal treatment or with any secondary fixation or splinting for the tooth. And this is the key of the success in the dental trauma, to have always follow-up for the patient. Don't make the treatment and send him home and say it's finished. We have to make follow-up to see how is the vitality of the bulb, to see how is the splinting results, is it again fixed or not. By this slide we can see that the follow-up procedure, what we need to do by follow-up procedure. It's not follow-up procedure, it means that you let the patient come and only take a look. You have to do something sometimes. And it depends upon the luxation or intrusion, extrusion, or what's happened by the trauma. This all depends on it. These tables, you can find it always. I can send you the lecture. We have here to summarize only how we deal with the dental trauma. By dental trauma, we lose the tooth. Why we don't think about substitute? We have to have a tooth for the patient. If it is a front tooth, the patient cannot live without a tooth. Even if he is 13 years old or 14 years old, it's a front tooth, it is static and like this. By this old, we cannot do a dental implant. You know that dental implant is allowed only by 18 years old or, yeah, at least to have dental implant, because it's not growing, the bone will not grow with the neighbor teeth, then we'll have problem. Then we will think about tooth auto-transplantation, which is, by this case, for example, we took the premolar, which has a priority by the orthodontics to be removed for orthodontics reason, and we transfer it in the central area, and then we can make for it filling, or we can make it for facing with the composite, and by this way we manage the losing tooth, and we have a fixed tooth. Maybe it will not last. Some people, they will say, okay, it will be by the auto transplantation, maybe root resorption will happen and like this, but it's enough if it lasts for 5 years to have at 18 years old his permanent implant. By talking now about the dental implant as a replacement for a tooth which we lost it in the trauma, we can talk about it as the same like by losing any tooth. It's not necessary to talk that trauma, it leads to any tooth lost, we have to replace the tooth, then we can make dental implant. Dental implant and losing dental trauma, it is mostly happen in the upper jaw anterior teeth. This is very well known for us. The most area which happened always the central and the lateral for the upper teeth. That means if we will do a dental implant, we have to talk about aesthetic. Aesthetic by dental implant is something needs very good planning. We talk about 3D planning nowadays, and now they start talking about 4D plannings. That means how we put the dental implant in a bone envelope in the right position to have the best aesthetic results at the end. By this slide, you can see that we have to study the patient very carefully before we start and see if there is a risk factors, is it low, moderate, or high, and make a score for the patient. By every patient for anterior dental implant, we start to see if he is the medical status of the patient, if he is a smoker or not, if the patient has high expectation of aesthetic, the lip line and everything about aesthetic, about the lips and the gum, and many factors we have to evaluate it. And after that, we have to do a scoring system to see at the end, is this patient suitable for dental implant, and what's his expectation and what's the end results, and to see if we need to do a very difficult augmentation with bone and soft tissue augmentation before we start, to plan it very well. This is the implant scoring system by aesthetic area, and as I told you, you have to have 1 point or 0 point for if there is I'm sorry, this is German, this is English down, yeah, you can read that down, that if there's a mesial papilla or distal papilla, or the soft tissue level, the soft tissue contour, and everything about the aesthetic, and then start to do, if it is very not available, for example, the mesial papilla, then we have to make 0 point, and then we see. At the end, we have here 7 points to score it. By every point, you can put maximum 2 points, then we'll have 14. If you have the best ideal situation that you have everything, you will have 14 points. By 14 points, go ahead and make directly the dental implant, because it's the best. It's very rare to find someone have that possibility. 14 points. I think if you have above 11 points by the score, then it is a very good patient, above 11. Below 10, then it will be moderate. Below 5, it will be very complicated case. Please don't touch it unless you are the suitable specialist person. Because if you have no papilla mesial, no papilla distal, and no soft tissue level is very difficult, and you have all of this in 0 point, then you will have a very complicated aesthetic dental implant in the front teeth. Then the scoring is very bad. It needs a very high specialty to do. Let's start with one case first. We have here this patient. He has a Boston core with the crown. By small trauma, he lost the crown, and the root fracture is very deep. As you see, we cannot save the tooth. We removed the tooth directly, and the same time we placed the dental implant. The dental implant must be placed in the right position, is not very buccally, and 2 millimeter away from the buccal plate. This is one of the most important thing, to have no bone resorption for the buccal plate, which is very important for the aesthetic later. After that, I did for the patient here a Maryland bridge, because the primary stability of the implant sometimes is not very high, to above 35 Newton. Then we need to have something as temporary. We did for him a Maryland bridge until the implant will be osseointegrated for the next 2 months, 2.5 months, and then we will do the crown. And here's the aesthetic results. As you see, if you give a score for this dental implant before and after, you can see that the mesial papilla is there, the mesial here, the distal here papilla is there, the contouring of the gingiva is perfect, and maybe is very little bit, about 1 millimeter higher than the central. This is one of the weak points, but aesthetically, you can give it for a score about 9 to 10, which is very good. And at the end, the scoring is, as I told you, is the number. The most important is the patient compliance of the case. And if you can see, it's very hardly to know that this is a dental implant in compared to the natural teeth beside it, that the dental lab did a very good job. To choose the dental implant for aesthetic, it is something very important. There we have now thousands of implant systems in the market. We don't want to talk about it by names and like this, but you have to do aesthetic implant, and you have to have some criteria in the dental implant. Not every dental implant is very suitable to the aesthetic area. Okay, the marketing, they told you, everyone tell you that his implant is the best, and his implant is very well osseointegrated and has very good results, but you have to be sure that you will choose the right implant. The right implant, in my opinion, must be without polished neck, which is here, for example, platform switching, submerged under the bone crystal, about 1 millimeter. It will be very good for the aesthetic area. To have a very good results for aesthetic, you need to have also conical connection. Conical connection, it will make a very good connection for the aesthetic area also, to prevent any screw loosening or to prevent any leakage for the dental implant. This criteria now is the modern implant systems. They have to have it. They have to have platform switching. They have to have, if possible, submerged under the crystal bone for 1 millimeter, and there's no polished neck, and there's a conical connection. Long conical connection, it will be also favorable, and the conical connection must be not more than 13 degrees to have this Morse effect, as you know from the prosthodontistry. That we have to have this Morse technique, which make the tube-in-tube system and make very, very stable abutment, no screw loosening, no leakage, and very high results for the aesthetic area. The implant surface must be, as we know, all acid etched or etching and sandblasting, and the design of the implant must be very high primary stability, self-cutting implant, and like this. Anyway, this is not the most important subject, but it is important also to know that the dental implant, it will play a role by doing an aesthetic zone. From the literature, we have some very important things, like that the immediate implant loading will achieve the similar success rate of those who reported in the delay stage approach. Nowadays, we don't think that the delay approach is the important thing to do, because we can do very immediate implantation, immediate sometimes loading, and the results by the reviews and the studies shows that there is no problem at all. Especially when the implant system, it has a very high primary stability, and as I told you, it has the criteria to use by the aesthetic area as immediate implantation. And the primary stability, as I told you, it's one of the key factors considered before attempting immediate implant loading. That means we have to have primary stability, and we have to have at least 35 Newton centimeter to have a very stable implant for the immediate loading. And surgery and host implant and the occlusion all of them, this is related factors may influence the outcome of immediate implant loading. We are talking about immediate implant loading because, you know, we have trauma and the tooth is lost and we need to have something quickly. As possible, nowadays we need everything quick. We are trying to find the quick way to go to the work, the quick way to make everything and have everything quickly. And the patient also wants his implant quickly. Okay, we don't want to have any risk about losing the implant, but we need to do something quick. Immediate implantation, now evidence-based, you can do it by removing the root, debridement the whole socket from infection or clean it. If there is chronic infection, no problem. By acute infection, is not allowed for sure to do immediate implantation. It must be chronic infection only. By chronic infection, if you make debridements very well, then you are allowed to do a dental implant in the same day by tooth removal. Because we know the protocol for implant loading also, we have something we call immediate, early, and conventional. The conventional is 3 to 6 months. This is the most of the people what they are doing. And the early protocol, which is 48 hours to 3 months, and the immediate is the 48. Actually, immediate 48, we do it mostly by all-on-4 or the full jaw rehabilitation, because we can connect the teeth together and we can make somehow real loading from the first day. By the early loading, we use it by the front teeth and by the aesthetic area, and by conventional we are using it for the posterior area because we can wait and there's no need for quick implantation. Very important to have the size of the dental implant regarding the place of doing the implant. Dental implant, it needs to be about, let me see here, about exactly 1.5 millimeter to the neighbor tooth, and between two implants, this is 3 millimeter. This is since 2004, very well known from Stroman. They have these studies since 2004 and everyone follow it. And very good planning and bone grafting, as we said, by bad scoring of the aesthetic area. If you find there's no papilla, there's no horizontal bone, is very down, we need vertical augmentation. We have to think how to do the augmentation with bone grafting and with soft tissue grafting also. By this case, you can see that the patient came with the old trauma, which is not treated very well for the tooth, and the tooth is elongated, completely out of the sockets. It was very, very high mobility. In the same day, I removed the tooth, I put dental implant. In the same day, we put also for him quickly a Maryland bridge to have his aesthetic at least for the next time until the implant will be osseointegrated. This is the how you see. I think it was not the same day, I'm sorry, it was in the early stage. We wait about 2 weeks until the soft tissue, only the soft tissue healing, and then we put the implant. But you can see the bone defect is very big. That's why after doing the implant, we have to make augmentation. We try by the incision to keep the papilla mesial and the distal papilla intact without making it in the incision to have more aesthetic result at the end. We did a membrane over the bone grafting and the implant, and we closed it with the, and this is after about 2.5 months. We removed the Maryland bridge. We can see here very nice soft tissue healing. And this is here some gum bracing by the abutment. This is zirconia abutment, and the implant is very well osseointegrated, and this is the end result. For good luck, we have here a patient who has a very low smile line. He has about 1 millimeter above the neighbor tooth, about 1 millimeter, but we can correct that with soft tissue graft. He doesn't like that. He said, it's okay, I don't have a high smile line lip. Don't be don't try to make over therapy if the patient is happy and the result is good, and we can maintain that after follow-up now 5 years. This is a professor in the Qatar University, a German professor in Qatar University, and he said, for me, I need the function more than, and I have to do, and not very high aesthetic requirements. But I find it was a good case. Now, for the aesthetic area, as I told you, you have to be away from the buccal plate at least 1.8 millimeter. Between the two implants is 3 millimeter. Between tooth and implant is 1.5. The smile line, you have to show the upper teeth, and the 3D or 4D tooth or implant positioning is very important. Okay. By immediate placement of the implant, you have to know that you need to put the implant in the palatal bone as possible and be away from the buccal plate to have a very good aesthetic results. 2 millimeter, it must be the implant away, or 1.8 at least millimeter away from the buccal plate to have a good position for the implant. Here we can see also a missing tooth, lateral tooth, is treated with a zirconia abutment and the crown and the aesthetic results. By this case, I can feel that there's no way to know where's the implant, where's the dental implant. It looks very nice aesthetically and very nice in compared to the natural teeth. The implant is here, is the lateral, actually. You can see by scoring, and this is lateral also, 2 laterals by this patient is, the pink aesthetic was perfect. As you see here, this is the 2 laterals by the implant edge. We have here sinus lifting, both sides for 2 dental implants, and here the orthodontist has some mini implants to do that also. You can see this case, this is the same case, how we did it all completely step by step, and how is the aesthetic results it was at the end. Here we have 4 front teeth. All front teeth, it was periodontal movement and problem. We remove the 4 teeth and do 2 implants by the lateral position. You can see how is the denture has some pontic issue. By the pontic, it has very nice soft tissue for doing the bridge. And this is the bridge after finishing the... Here we put 2 abutments from titanium. To do planning on the OPG is possible, but I think to do planning on the CT scan, it's more 3D and 4D planning, which has the priority nowadays because it's available. This is here a posterior tooth with the single tooth of premolar with zirconia custom-made abutment. It was a very nice case also, and the end results, it was very aesthetic. We can talk about the dentolabial aesthetic and how the lips with the teeth sizes and everything, how it must be, and make also scoring for that. And after that, make evaluation for the case before we start. I'm sorry, I have to be a little bit quick. I took a long time. And by aesthetic success, we can say that the pink aesthetic score, the PAES, from 7 points by this study. And by this study, Belzer, it has a 5 index. And I advise you all, if you want to do aesthetic area dental implant, to have a score system for scoring before doing any dental implant. You can see that by lower anterior teeth, we lost this teeth because he has trauma also, and after that, by splinting the teeth, we lost the tooth after that. And we can substitute 2 centrals in the lower jaw by 1 implant and do cantilever for that. This is also anterior case and central. It was a very nice aesthetic results. I can show you a lot of cases. This is here also a case of lower anterior teeth with the canine. They splint all teeth together, and you can see how is the splinting long time. Sometimes it has a very bad results because he lost all the teeth. It was all mobile, and we have to make augmentation, bone grafting, and the bridge at the end, as you see here, it has. We have to be pink ceramic because we substitute now 6 teeth in 4 implants. So, this is a posterior case. I have actually no time. I will go to the summary at the end. This is a case with the upper and lower all on 6. The take-home message that we need to say that when you treat a traumatic dental injury, the timeline, the timelines is very important and critical, and the proper management of the dental trauma is most often a team of effort. You have to have a dentist and the whole team, and also we have to have a general dentist and pediatric dentist, periodontist, and sometimes oral surgeon to have the treatment for the trauma, dental trauma. The compliance with acceptance dental trauma treatment guidelines has been shown to improve the outcomes. And we have to talk about also that the dental implant in aesthetic zone have a special need of a 3D or 4D planning to have the best prosthetic results. Thank you very much. That was a great honor for me to see you today. I hope that it was an informative lecture. Thank you very much.
Thank you, Dr. Taraben. We have time for one quick question. Do we have a microphone? The lady in the front, if you can speak loudly without the microphone, or we can wait.
Any contraindication to practice sport after implants?
To practice sport after. Yeah, dental implant surgery means it is a surgery at the end, and we have to prevent the patient from doing hard exercises, because this will lead to more bleeding, to more trauma in the first week. And that's why we advise always not to have any severe or hard training after 1 week at least after any dental alveolar surgery, not only dental implants. Yeah.
Okay. Thank you very much, Dr. Taraben.
Thank you. Thank you.
I'm sure he'll be around for questions during